Well, for those of you, it's not past your bedtime. Thanks for listening. It is a great honor to be asked to speak at this symposium by Dr. Wyman and Dr. Bire. I can't say enough about Dr. Bire's passion for making sure that our new therapies and our old therapies are applied to a wide spectrum of Americans. So I'm happy to debate Dr. Kantarjian, who's one of the leaders in hematologic malignancies in the world. It's a very humbling experience. Debates, of course, as you told me this afternoon, it's an artificial way to exchange information. Debates are highly imperfect. If debates were perfect, we wouldn't have threats to science. We wouldn't be firing dedicated government workers. We wouldn't be cozying up to a bloodthirsty dictator, amongst just a few things that imperfect debates got us. If you disagree with me, you're more than entitled, because it's still a free country for a few more minutes. So anyway, well, okay, enough of that. So I'm going to be talking about pediatric regimens in adolescents and young adults with ALL and why I think they are now the standard of care for this group of patients with acute lymphoblastic leukemia. Here are my disclosures. Now, if you don't believe me, and I encourage you not to believe me, but believe AI. Who does not believe AI? So I said, I'm not going to prepare these slides. I'm just going to Google AI and see. And I said, which is better for the adolescents and young adults, pediatric or standard regimens? And it says right here, this is literally taken from the internet, when comparing pediatric therapy to hyper-CVAD for treating ALL, pediatric regimens are generally considered superior, offering better overall survival rates and potentially less severe side effects, especially for adolescents and young adults. This is because pediatric protocols are often more targeted and optimized for younger patients, incorporating higher doses of certain drugs like asparaginase while minimizing potentially harmful toxicities associated with hyper-CVAD regimens. So if anybody didn't think that AI is going to make doctors irrelevant, there it is. See ya. No. I'll explain to you the data that caused AI to come to this conclusion, which is what I'd like you to all believe at the end of my talk. I'm going to go through in the next 12.5 minutes how folks thought of using a pediatric regimen for young adults, some of the legacy data, the current data, and a little bit about the future. So this is how we approach ALL. Basically, most of what I'm going to be talking about today applies to both T cell and B cell, but using some of the newer agents, which are mainly just for B cell, it does not apply to T cell. I'm not going to be talking about Philadelphia positive disease today, which is now also a highly curable neoplasm, thanks to the use of tyrosine kinase inhibitors. Now, I think everybody in the audience knows that one of the great success stories in oncology over the past few decades has been the improved outcome for kids with ALL, and everybody shows the slide on the left. And the slide on the right shows that we weren't able to make much improvement over the years in older adults with ALL, but even if you look at those who are under age 20 treated with an ECOG 2993, we only had a 40% cure rate. So why was that? Wendy Stock, who's a very good friend of mine and a wonderful colleague, looked at people who were between 16 and 24 and just asked the question, if you walked into an adult doctor's office versus walking into a pediatric doctor's office, which was likely to, if you had ALL, which was likely to lead to a better outcome? And this graph on the right shows that if you walked into a pediatric doctor's office and got a pediatric regimen, you did significantly better. That was retrospective data. What was the reason for this? These were people with the same biological characteristics and age by and large. What was the reason for this? Maybe it was because they had better therapy, which I think they did. Maybe it was because the type of patients who walk into a pediatric doctor's office with their mother and make sure they take the medicines on time versus the other ones who come to my office or have a guitar in their back and are smoking dope. It's a different group of people, but I think it's really the regimen. So also, one clue was that the CNS relapse rate was much lower in kids in the pediatric regimens than in the adult regimens for the same group. And if we look at our hyper-CVAD, which is a fantastic regimen that Dr. Kantarjian and colleagues developed at MD Anderson and is used worldwide for ALL and similar diseases, there it is there. It's a repeating sort of cyclophosphamide vincristine anthracycline with high-dose methotrexate and fairly high-dose cytarabine, and it keeps going like that for a while. And Dr. Thomas, Dr. O'Brien, Dr. Kantarjian showed that adding rituximab in the roughly 40% of people who are CD20 positive can get your CR duration fairly respectable. Dr. Larson, who was here earlier today, I just shook hands with him as he was leaving, did a series of trials when he was the chairman of the Alliance Committee. My wife always calls me when I'm giving a talk. Anyway, maybe that's because I talk so much, I don't know. But it showed that what the outcomes were. These are adults up to age 60 roughly. You can see about a 40% long-term progression-free survival. So let's focus on people between 18 and 39. And what an adolescent and young adult is a relatively loose term. You can see in France where they apparently stay young until they're 60, whereas an adult in America, we age more quickly. But anyway, what is different between a pediatric and an adult regimen? There are multiple chemotherapy drugs in both, but clearly the pediatricians have used more L-asparaginase and corticosteroids, less myelotoxic drugs. Remember, in adult leukemia doctors, we used to slam in people with high-dose myelosuppressive therapy. That's what we do, and a lot of the adult regimens reflected that. We want to make sure that the people are a little bit more anal about making sure that people take their drugs on time and get the right dose, and we reserve allogeneic stem cell transplant for only high risk. Now, the toxicity of these pediatric regimens is not benign. You can see here comparing Wendy Stock's pediatric-like therapy in people up to age 40 to the standard ALL therapy in children and teenagers with ALL. The toxicities are higher in the adolescents and young adults with very similar regimens. So we have to recognize that kids are more resilient than the adolescents and young adults. But asparaginase is a different kind of drug, as you all know. It depletes asparagine from lymphoblasts that require it for maintenance of they can't make it from other substances. And of course, this asparagine depletion comes with a price: hypoalbuminemia, high blood sugar, altered drug metabolism, procoagulation, and hyperglycemia. And we can see that as you deplete asparagine in older people, you have a shockingly high incidence of VTE, venous thromboembolism, and we have to be careful about that. We use it, though, because it's a very effective drug in kids and adolescents and young adults. If you can see, if you don't get asparaginase, you do worse than if you do get asparaginase, to make a long story short. And this is a pediatric study that showed the same thing. And I'm not going to get into the machinations of what type of asparaginase is available or not available in the various age groups. It's a little bit complicated. These are the regimens that we did at Dana-Farber when we saw Wendy's data, and we said, well, we're going to just copy our buddies down the hall who give the pediatric regimen to the kids. This was done in the US and Canada when it was still a different country. Somebody got that at least. So it's a tough crowd, my goodness. So anyway, basically we copied the pediatric regimen. We updated it with more dexamethasone in the second iteration. And the data that were published by Dan and myself on the right shows that we seem to do better than historical controls using more legacy-type adult regimens. So that's really the first point, that pediatric regimens are better than legacy adult regimens for similar age people. And when we made a few tweaks to the regimen to make it safer, we haven't published this yet, but this was presented by Dan at ASH a couple of years ago, and you can see a 75% long-term survival with pediatric regimens. Wendy Stock showed that this could be done throughout the United States and Canada, included people of all socioeconomic backgrounds, because the Alliance has, and the intergroup had, places all over the country in all types of areas. 72% 3-year survival, and it was good for both B and T cell disease. And a few little interesting sidelights was that if you had a Philadelphia-like signature, that's RNA expression like it, as if you had the Philadelphia chromosome but don't, you did a little bit worse. If you were, had a high BMI, which is an important issue, and of course a lot of Americans are overweight, you did a little bit worse as well. If you can get MRD negative, no surprise, that's a theme, right? You do better than if you're MRD not negative. Matt Seftel from Canada looked at retrospectively at people who got transplants and actually showed that the chemotherapy regimens given in the DFCI regimen obviated the need for stem cell transplant. Again, retrospective data. But listen, I'm going to admit that our regimen is tough. A lot of our men with, or young men with getting this regimen who got a lot of steroids get osteonecrosis and require surgery. And as I already mentioned, BMI is a big issue. It's really not modifiable easily. Anticoagulation, we have been able to decrease the VTE rate by using low molecular weight heparin, holding it when the platelets low, obviously repleting antithrombin 3 if the antithrombin 3, which is of course a natural anticoagulant, is too low. And we hold anticoagulation during procedures and stuff like that. And so just to finish, I'll show you how the pediatric regimens can be even a little bit more improved with the use of wonderful agents, which Dr. Kintarjanam himself was key in developing: blinatumomab, bispecific antibody, CD3, CD19, and inotuzumab, anti-CD22 antibody drug conjugate. And these are being added to the pediatric-like regimen that we showed. Dr. D'Angelo, my colleague, presented this at ASH, which is the early look at CLGB 10403, which was an attempt to add inotuzumab, the antibody drug conjugate, to a pediatric-like regimen that Dr. Stock had developed earlier. And we had to stop the trial early because of increased deaths late in the chemotherapy part of the trial before the maintenance. And so what was going on there? The good news was event-free survival in both arms was pretty good at 70% roughly at 3 years. The bad news was inotuzumab did not improve the event-free survival because that was the whole point of the study. And why was that? If you look at the bottom, you can see that it wasn't because inotuzumab wasn't, quote, working. There was actually a lower progression rate in those who get inotuzumab, but it did cause a higher death rate. And that was maybe because the inotuzumab made you less able to tolerate chemotherapy late when it was after it was given. Yet the 3-year overall survival was good, and the 3-year overall survival was 80% in this study compared to CLGB 10403, the backbone prior study. So maybe we were actually improving this up to almost pediatric-like levels, and it was clearly much better than historical CLGB survival of 46%. So although it didn't meet the primary endpoint, it was because of toxicity that occurred. And of course, we also have blinatumomab to add to pediatric-like therapy. Now this is Mark Litzau's led ECOG 1910 trial, which was done in a little bit older adults, so there wasn't much overlap in age between the two studies, the Dan study and Mark study, but this one added blinatumomab, but the key here is this was randomizing blinatumomab in patients who were MRD negative after the initial chemo, because blinatumomab during the course of the study was approved for MRD positive patients. So they said, we'll just randomize the MRD negative patients. Some people scratch their heads when they hear that because they say, well, why would you give an antibody if there's no disease? Well, MRD negative just means we can't measure it, so we're eradicating minimal disease. And of course, in the regimen is, you can all read that, right? But the regimen is similar, it's sort of a cross between the legacy regimens and the pediatric regimens, but lo and behold, there was a major benefit to getting blinatumomab for MRD negative. So I'm saying that if you add blinatumomab to pediatric-like therapy, you can get wickedly high, as we say in Boston, long-term survival. And there was another, since these slides were made, the top thing on the right was actually published. The pediatricians did a similar trial in kids and showed that adding blinatumomab was also effective in kids with ALL. And finally, Dan and others are going to be publishing this thing, which looks at basically a meta-analysis looking at a lot of retrospective data and showing that, the pediatric regimens with a lot of L-asparaginase in them are better. So in summary, comparing studies using each strategy in the same age group suggests pediatric-inspired regimens lead to better event-free and overall survival in hyper-CVAD. Meta-analysis suggests that pediatric-inspired regimens are better, toxicities are different but manageable, and use of targeted therapy may improve results even further. So I hope I haven't offended too many people, and I'm looking forward to what Dr. Kantarjian has to say, because I always look forward to what he has to say. Thanks again for listening.